Mnemonic we
Recording in
remembered for all the
progress.
layers. So you know this concept of the stratum basal cells are going to divide, proliferate. That's the reason why it is called as no volume on YouTube. So is it so? So I think there is some glitch, but here all the students are able to listen to my voice. So there should be no problem. Okay, so stratum basal layer. Stratum basal layer is a stratum germinativum which is going to produce all the rest of the other layers, and it takes approximately 42 to 75 days for all the this stratum basal to reach the stratum corneum and get shed off. This is called as epidermal turnover time. And here there is one clinical point which you have to remember. A disease called as psoriasis, which is a papilloscomus disorder. Here the epidermal turnover time is going to reduce by 4 to 7 days. That is the reason why we are going to see in these patients silvery white scaly plaques over the skin clinically. And apart from that, we are going to see the presence of the nucleus in the stratum corneum, which is what is called as a parakeratosis. So many MCQs are there in this particular concept which I have explained you just now. Okay. Next, coming to the cells of the epidermis, the majority of the cells in the epidermis are going to be the keratinocytes, which are going to form approximately 85 to 90% of the cells. And these are ectodermal in origin. Apart from the keratinocytes, we are also having three other cells. What are those? Langerhans cells, Merkel cells, and melanocytes. So these are also very important. So we are going to see very important points related to them very, very quickly. Langerhans cells, these are the antigen presenting cells which are present in the stratum spinosum. They are originating from the bone marrow or the mesoderm. And remember, if you do electron microscopy inside these Langerhans cells, we are going to see this tennis racket shaped Berbeck granules. Okay, these are the important points to remember. Melanocytes, Merkel cells, both of them have one thing in common. Both start with the alphabet M. So remember this song, Baby ko base pasand hai. So we are just making a remix. Munne ko base pasand hai. Basal layer is the address for both these cells, M for Merkel cells and melanocytes. And about melanocytes, very important points to remember. It is originating from the neural crust cells. In anatomy, you might have done this. NC is a very, very important point to remember. And inside the melanocytes, melanosomes will be there, which are going to produce this melanin pigment from precursor. What is a precursor? It is tyrosine. Tyrosine from the rate limiting step, which is the tyrosinase enzyme. Okay. And coming to the melanocytes, you can see they are present in the stratum basal layer. And there is one concept called as epidermal melanin unit, where one melanocyte is going to give the melanin pigment to the adjacent 36 keratinocytes. So this number is called as the epidermal melanin unit, 1:36. Coming to the Merkel cells, they are ectodermal in origin, just like the keratinocytes, and they consist of neurosecretory granules which help in the touch perception. Mechanoreception is basically the function of the Merkel cells. Next layer which you have to remember is the subcutaneous tissue, which is also called as the hypodermis. Hypodermis because it is present below the dermis, below the dermis. And this is the layer in which we are going to. So is the voice okay? So I will try to increase the voice a little bit. Okay. So is the voice now okay, or now is it very high? Okay, ठीक है. So hypodermis, it is going to have the what is called as, yeah, adipose tissue, and inside this we are going to have the fat lobules. Inside this we are going to have the fat lobules, and this is also called as, this hypodermis is also called as panniculus. Panniculus. If there is inflammation of this panniculus, we are going to call it as panniculitis. Panniculitis. And what are the two important diseases in which panniculitis is going to be seen? One is Buzzin's disease. The other one is erythema nodosum. Erythema nodosum. Basically, both of them are the cutaneous tuberculosis. Okay. Next, related to some dermatopathological terms which you have to remember. So, stratum spinosum layer. Anything related to stratospinosum, we are going to use this term acantha. If there is thickening of the stratospinosum, we are going to call it as acanthosis. If there is a disruption of the desmosomes which are present in between the keratinocytes, we are going to call it as acantholysis. Acantholysis is going to be observed with the help of the Zank smear. That is the reason why the cells which are going to be produced, which are acantholytic cells, these are also called as the Zank cells. These are also called as the Zank cells. Zank cells. And how are they going to appear? Just like you are seeing this picture, the yellow arrow is pointing towards a round cell which is having central nucleus, hyperchromatic nucleus, and a perinuclear halo. So these are the three characteristics of a Zang cell or acantholytic cell. And what are the conditions in which we can see the Zang cells? They are very, very important. Autoimmune condition, pemphigus must be very, very importantly remembered. Apart from that, bacterial infections, like for example, the bullous impetigo and also staphylococcal scarlet skin syndrome can have this acantholytic cells or Zang cells. Apart from this, viral infection, very good. Yes, herpes simplex virus and also varicella zoster virus. In all these conditions, we can see the presence of the acantholytic cells or the Zang cells. Very important point to remember. Okay, asked so many times in the examinations. Some one-liners we can say. So average weight of the skin in kilograms is 4 to 5 kilograms. Deepest layer of the epidermis is stratum germinativum. Stratum germinativum is also called as stratum basal layer. Synthesis of keratin mainly takes place in this layer of the epidermis. It is stratum spinosum. Oddland bodies are seen in this layer of the epidermis. Where are the oddland bodies seen? In the granulosum layer, it's going to consist of keratohyalin granules and also the lamellar granules, which are nothing but the oddland bodies. Okay. Stratum lucidum is present in between which two layers? Come, let's get sunburn. Come, let's get sunburn. Okay. Stratum corneum and granulosum. In between these two layers, it is present. This we have already discussed. What is Malpighian layer? Bottom two layers put together, we are going to call it as a Malpighian layer. That is stratum basal layer and stratum spinosum layer. Okay. Principal cells of the epidermis, keratinocytes are the principal cells. Substance which is common for skin, hair, and nails, it is the keratin. Langerhans cells are present in stratum spinosum layer. Very important. Merkel cells and melanocytes basal layer. Fat is present in hypodermis. Okay. Parakeratosis is the presence of the nucleus in the stratum corneum, and it is present in which disease? You should remember it is psoriasis. Very, very important point. And also they may also give you the picture. So here in this picture, you can see this arrow is pointing towards the stratum corneum layer in which the nucleus is still present. So this is parakeratosis. Hyperkeratosis is thickening of the stratum corneum. Acanthosis, we have already seen. Acantholysis, separation of the keratinocytes because of the damage of the desmosomes, right? Diascopy is done for observing. What is diascopy? It is pressing the skin with the help of a glass lid is what is called as diascopy. And this is going to help us to differentiate between the erythema and the petechiae purpura ecchymosis. In erythema, we are going to see this blanch response, whereas in petechiae purpura ecchymosis, no blanch response will be seen. And apart from that, even the granulomatous conditions which are going to present as the red lesion over the skin, if you press with the glass slide, we are going to see the presence of the golden brown apple jelly nodules, which is very classical for lupus vulgaris. And also we can remember cutaneous leishmaniasis can also show this, and also sarcoidosis can also show this. Okay, right? Zang smear shows acantholytic cells. Very simple point, right? Next is some lines in the dermatology which are important to remember. One is Blaschko's lines, Langer's lines. Langer's lines are also called as RSTL. What is RSTL? Relaxed skin tension lines. RSTL stands for relaxed skin tension lines. And remember, this can be asked in the exam as one of the options. Okay, so what are Blaschko's lines? Basically, these are the pathways of the epidermal cell which are present during the embryonic development. They are going to migrate. So this epidermal cell migration is going to create some patterns for the skin. This is Blaschko's lines, and these do not correspond to the arteries, veins, nerves, and lymphatics, and these are going to be constant throughout the patient's life or any person's life, and they are going to be easily identifiable. Over the scalp, they are spiral in nature. Over the upper back, they are V-shaped. Over the anterior aspect, they are S-shaped, and over the extremities, they are linearly arranged. And also, if you observe carefully, there is going to be this midline demarcation. So these lines do not cross the midline. Do not cross the midline. Whereas if you see the next one, that is the Langer's lines, you can see they are going to cross the midline, and these are basically the collagen fiber orientation which are present over the body. What is the significance of this clinical significance? Whenever you go incision, you have to give the incision along or parallel to these lines to prevent any unnecessary scar formation during the healing process. And how can you identify this? Very simple method. If you remember the Thanos, the face, the lower half of the face of Lord Thanos, and the Langer's lines is going to be almost the same. So you can remember Lord Thanos and Langer's lines. Okay, look one and the same. And also not only that, these lines are going to cross the midline. There is no midline demarcation. That is one more way to remember. And this is how the examiner can ask you a question. They can give you a picture and they can give these options. You need to identify. Here it's going to be the option B, Blaschko's lines. Yes, absolutely correct. Next is we are going to see the vesiculobullous disorders. So vesiculobullous disorders, you should know the buzzwords which are going to be mentioned by the examiner. Very, very important. With the help of these buzzwords, you are going to differentiate between the vesiculobullous disorders. At least you can rule out the options if you are not very sure. So what is the important buzzword is intraepidermal blistering disorder, flaccid blisters will be mentioned. Intraepidermal flaccid blisters, intraepidermal flaccid blisters. Tense bullae, tense vesicles, if they are mentioned, the subepidermal blistering disorder, subepidermal blistering disorder. That is what you have to remember. Flaccid is like this, wrinkling over the surface will be seen. So we are going to first cover the acquired conditions where flaccid blisters will be in. That is, we are going to discuss the intraepidermal blistering disorders, Pemphigus group, Pemphigus foliaceus, and Pemphigus vulgaris. Apart from this, there is one bacterial infection associated with the toxin, which is staphylococcal scarlet skin syndrome. So these three we are going to discuss. The first one is the flaccid bullous lesions produced by the Pemphigus vulgaris. Remember, in these patients are going to have the antibodies. Again, is the desmoglein number 3 more than desmoglein number 1. And remember, desmoglein 3 is present in the mucosa. So these patients are going to have a very, very bad mucosal involvement where there are going to be ulcerations and erosions over the buccal mucosa and also over the gingival mucosa. Apart from this, they are going to be flaccid bullous lesion obviously present over the body, and these lesions are going to spread to involve the entire body. Sometimes patient may die because of this condition if it is not diagnosed and treated on time. So diagnosis is very, very important. That's the reason why we have various investigations to do in these vesiculobullous disorders. So first one we can do the Zank smear. In the Zank smear, we are going to see the acantholytic cells in these patients. If you do a biopsy, in the biopsy, we are going to see this very classical row of tombstone appearance. Very, very important point to remember. And also in the bedside, we can also perform this Nichols kiss and the recent INA question. So where we are going to apply gentle tangential pressure on the skin because of the underlying acantholysis, the skin is going to peel off very, very easily, and this is what is called as Nichols-Kissen. And remember, Nichols-Kissen is positive in the cases wherever there is acantholysis seen, and it is not going to be seen in those conditions where acantholysis is not seen. So Nichols-Kissen is going to differentiate between the intraepidermal blistering disorders and subepidermal blistering disorders. In subepidermal blistering disorders, there is no acantholysis, so Nichols-Kissen will be negative. This was in fact the recent INA question also. Okay, right. Next, this is a row of tombstone appearance. So if you see, this is the epidermis and this is the dermis. We have in the epidermis the stratum basal cells which are present like this attached near the dermoepidermal junction, and because the stratum basal cells are attached to the underlying dermoepidermal junction with the help of not desmosomes but hemidesmosomes, that is the reason why in the patients of Pemphigus vulgaris, though they are antibodies against desmoglein, hemidesmosomes are absolutely normal. So that is the reason why the stratum basal cells are still attached to the underlying dermoepidermal junction, giving rise to this very, very, very important row of tombstone appearance. And even the image can also be given by the examiner. So you can see this is the entire layer of the epidermis except for the stratum basal layer, which is still attached to the underlying dermoepidermal junction. So this is what is giving rise to the row of tombstone appearance. Tombstones are graveyard. There will be stones. Those are the tombstones. And this acantholytic cell, which can be seen in these patients of Pemphigus vulgaris. And also apart from that, you can do an investigation which is the direct immunofluorescence, which is the investigation of choice in the patients of the vesiculobullous disorder lesions. So we are going to say the fishnet or chicken wire pattern because of the deposition of the IgG and C3 in these patients. Very important point, DIF. It can be given as an image based question also. You should be able to identify that it is a DIF. And you can see here the very, very beautiful what we can say, the rete ridges and the dermal papillae are separating the epidermis from the underlying dermis. Coming to Pemphigus foliaceus, in this the problem is patients are having the antibodies against the desmoglein first. So it is desmoglein number 1 first. So these patients are going to have mucosal sparing. Otherwise, the body is going to have the effect, that is there's going to be the subcorneal split in this patient because desmoglein 1 is present superficially, subcorneal split because the vesicular bulla is very, very, very flaccid, the roof is very thin. So that is the reason why in these patients we definitely may see some of the fluid lesions, but it's very difficult. But otherwise, these patients are going to mainly present with scaling. And also remember, mucosa is made up of desmoglein 3 majority. So that's why mucosa will be completely spared. And also remember, the seborrheic areas are the ones which are going to be affected in these patients. And of course, Nichols can be positive, and acantholysis can also be seen in these patients. Right? Now coming to the staphylococcal scarlet skin syndrome. So here remember the bullous impetigo. So this is just the extension of the bullous impetigo concept. So bullous impetigo, what is the causative organism? It is staphylococcus. Staphylococcus, because of its toxin which is produced, which is the exfoliative toxin A and exfoliative toxin B. This toxin is going to spread through the blood, and it is going to cause the damage to the desmoglein number 1. Because of the desmoglein 1 is damaged, the child is usually staphylococcal scarlet skin syndrome affects the children. Okay, and the skin is going to appear as if it has burned. So it is what, that's why it is called as a scarlet skin syndrome, staphylococcal scarlet skin syndrome. Children are going to have fever. If you handle them, there's going to be a lot of tenderness on the skin. They will try. And if you do Nichols question, it will be positive because acantholysis is positive in these children. Okay. Next, we are going to see the blistering disorders where the tense lesions are going to be seen. So these are subepidermal blistering disorder, bullous pemphigoid, and dermatitis herpetiformis. These are the two important conditions you need to remember. The first one is dermatitis herpetiformis. So remember, the clinical picture in these patients is going to be grouped papulovesicular lesions, which are very classically situated over the extensor surfaces, the elbows and the knees. And also these patients are having an important association, which you might have also read in the pathology. So there's going to be gluten sensitive enteropathy, celiac disease. So these patients are going to have some problems with the bro. So who is the bro? Barley, rye, oats, and the wheat. Barley, rye, oats, and wheat. These patients, if they take any of these food items, then there's going to be the GI symptoms, and also along with that, there's going to be this skin involvement in the form of this small papulovesicles over the extensor surfaces. And if you do a biopsy, in the biopsy, what are we going to see? The papillary tips are going to show the collection of the neutrophils, which is called as the papillary tip micro abscesses. Just like as you can see in this picture, these are the dermal papillae consisting of a vesiculobullous formation, and also the neutrophils are present as a collection in these patients. And if you do a DIF, there's going to be this IgA deposition in a granular fashion along the dermoepidermal junction and also in the dermal papilla. So this is the classical picture of the dermatitis herpetiformis. What is the treatment of choice? If I ask you treatment of choice, it's going to be the gluten-free diet. And if I specifically ask you the drug of choice, what is the drug of choice? Please remember, it is dapsone. So treatment of choice is avoiding the gluten diet. Drug is dapsone. Okay. And coming to bullous pemphigoid, in these, the patients are going to produce antibodies against bullous pemphigoid antigen 2 and bullous pemphigoid antigen 1, which are nothing but the hemidesmosomes. And usually these are going to be very elderly patients, right? And the lesions are going to be the tense bullous lesions which are present over the body, and the patients are going to have extreme itching, very itchy condition. And if you do a Zank smear, we are going to see the presence of the eosinophils in these patients. And at the base of the tense bullae, we are going to see this very classical urticarial wheels, as you can see in this picture, urticarial wheels, and that is one of the reasons for itching in these patients. And if you do a biopsy, we are going to see the subepidermal blister. And if you do a direct immunofluorescence, we are going to see the IgG and C3 deposition in a linear fashion along the base phenomena zone or the dermoepidermal junction. Okay, so this is the picture where you are able to see the epidermis and the dermis here, and you can see the beautiful immunofluorescence in a linear fashion along the dermoepidermal junction present in these patients, right? So these are the DIF findings, which could be given as image also. So you can see this pemphigus vulgaris. There is this beautiful fishnet or chicken wire pattern, right? And this second picture, which you can see, this could be the picture for both bullous pemphigoid as well as linear IgA disease. So remember, this is showing the linear deposition of the IgG in the case of bullous pemphigoid. And if the deposition is IgA in a linear fashion, then you should think of the linear IgA disease, which is also called as CBDC, chronic bullous dermatosis of the childhood. Chronic bullous dermatosis of the childhood. Next, this is the dermatitis herpetiformis, where how can you identify this? So you can see these are the dermal papillae, and this is the epidermis, and this is the dermis. At the papillary tips, you can see this granular deposition of the IgA. So this is dermatitis herpetiformis. Okay, so this is how you can examine in the exam. The examiner may ask you these type of questions as images. Also, you should be able to identify the answers. Right. Next is pemphigus vulgaris. So these are some of the one-liner questions. Pemphigus vulgaris, it is basically autoimmune disorder where we are going to see the acantholytic cells. Pemphigus bullae are intraepidermal blistering disorders, pemphigus vulgaris. So pemphigus vulgaris can be seen due to autoantibodies against which of these desmogleins? So remember, both these can have the antibodies. So option C most likely could be both of the above. So read very carefully all the options and then only try to mark the answers. Pemphigus foliaceus, F for foliaceus, F for first. So is a condition in which there is going to be antibody against desmoglein number 1. Row of tombstone appearance can be seen in the condition the pemphigus vulgaris, because here we are going to see the split at the suprabasal level. Intercellular antibody deposition on the immunofluorescence can be seen in pemphigus vulgaris because the desmosomes are present in between the cells. So intercellular antibody deposition with IgG and C3 is seen in pemphigus vulgaris. So bullous pemphigoid and also dermatitis herpetiformis and also linear IgA disease. So all these are subepidermal blistering disorders. So can you identify this immunofluorescence finding which you are seeing this? Can you tell me what is the pattern of this? Where is this immunofluorescence seen? Yes, very good. It is linear and you are able to see it between the epidermis and the dermis. So this could be bullous pemphigoid or it could be also linear IgA disease. Very important to point to remember. If I tell you what is deposited, then only you can diagnose it. If it is IgG which is deposited, then it is BP. But if it is IgA, then it is linear IgA disease. So linear deposition of IgG, it is bullous pemphigoid, which will show Nichols kiss sign and bullous spread sign, both of them positive. Remember, it is pemphigus vulgaris. So remember, in the cases of bullous pemphigoid, which is a subepidermal blistering disorder, Nichols kiss sign will be negative. Again, I am trying to reiterate this point. Very, very important. Very, very important. It is negative, right? Subepidermal blister formation, neutrophils located at the tips of the dermal papilla. What is the drug of choice? So it is DAP. So now if I ask you the same question, what is the treatment of choice? Then what will the answer for that? Yes, then it is going to be the gluten-free diet. Bro should be avoided. Dermatitis herpetiformis is going to show the IgA deposition and the papillary tips. Okay. So this is all the same thing. Right, now coming to the next topic, that is the hair. Okay, so in the hair you have to broadly remember the hair is going to be loss of the hair. That is what is important to remember in the hair topic. So that loss of hair could be permanent in the form of the scarring alopecia or cicatricial alopecia. No, some of the names of the causes, that is lichen planus is one of the cause which produces lichen planopilaris leading to scarring alopecia. Granulomatous disorder, sarcoidosis can produce this scarring alopecia. Systemic lupus erythematosus, SLE patients can also have scarring alopecia. Fevers and Kirion, these are the variants of the scalp dermatophytosis, that is tinea capitis. Apart from that, even this frontal fibrosing alopecia. So this was very favorite AIMS question. So frontal fibrosing alopecia condition is going to show this fibrosing, that is scarring type of alopecia. Now coming to the very, very important, broadly discussed, described non-scarring alopecia, that is non-cicatricial alopecia. Here you should remember broadly how is this non-cicatricial alopecia classified. The most important one obviously is the patchy type of alopecia, in which the most important disease to remember is alopecia areata. Apart from that, in psychiatry you might have heard about trichotillomania. And in tinea capitis, remember black dot and gray patch are going to also produce this patchy type of alopecia. Secondary syphilis, which is going to produce moth-eaten alopecia. Again, very important image-based question. The examiner may ask you, it was asked in the NEET also, moth-eaten alopecia. Coming to the diffuse variety of the hair loss, which is called as effluvium. Telogen effluvium, most likely, maybe after examinations, you might also experience this, because those who are in the stress, like for example, the pregnancy, the infections, or any kind of major surgery, after the stress is gone, after 3 months, we are going to see the hair loss, diffuse hair loss over the scalp, and this is what is called as telogen effluvium. There is one more effluent which is called as anagen effluent. Because of the chemotherapy and radiotherapy, there's going to be this hair loss. That is telogen effluent, and many celebrities also experience this issue. You might have also known that. And androgenic alopecia is a pattern hair loss. Okay, systemic cause is salient thyroid dysfunction. So these are some of the very important causes for the hair loss. So we are going to see some of them which are very important. First one is alopecia areata. So remember this some important points. Remember, it is an autoimmune condition which is going to also have association with other autoimmune conditions, like for example type 1 diabetes or Hashimoto's thyroiditis. Remember, any autoimmune condition can have an association with other autoimmune diseases also. Example, the skin condition vitiligo is autoimmune, so it can also have association with thyroid dysfunction. Okay, right. And in these patients, if you do a biopsy, we are going to see this swarm of these appearance because of the lymphocytes which are present at the hair bulb. And these lymphocytes are the one which are actually causing damage to the hair bulb, leading to the development of this patchy alopecia, in which we are going to see the complete loss of the hair. Not only that, if you see the hair very carefully, the hair is going to appear very exclamatory mark like appearance will be there for the hair, which is going to be very thin at the proximal part and very broad at the distal part, right? And if you examine the nails of these patients, the examination is going to reveal the pitting of the nails of these patients. And also, this condition is going to affect only the black or pigmented hairs. Unpigmented or those hairs which are not having the melanin pigment will be spared. So that is the reason why going white overnight phenomenon can be seen in these patients. And there are so many variants of this alopecia areata, not only just patchy hair loss. If there is loss of the entire scalp hair, we are going to call it as alopecia totalis. And if the entire body hair is lost, it is called as alopecia universalis. Okay. And what is the treatment for this? It is going to be the ILS. Intralesionally, we are going to inject the steroids into the lesion. And if you remember this, you know that Will Smith's wife, Jada Pinkett Smith, actually had this alopecia areata. So entire world exclaimed because of the slap of the Will Smith. So that will help you to remember the exclamation mark here sign, which is seen in the case of alopecia areata. Next is trichotillomania. So remember, in this one point to remember is whenever the patient plucks the hair, there is going to be damage, and this damage is going to produce what is this called as the so if you do a biopsy, we're going to see this. There is going to be the hemorrhages. This is going to be mentioned as histopathological examination finding showing the hemorrhages. Apart from that, that is the bleeding is going to be seen in the histopath picture. And also we can see these patients are going to eat the hair also. Very ugly feel I'm getting even just to tell this, but the patients are going to somehow like it. So it is called as, it is going to form a ball like thing. It's called as trichobezoar in the stomach. Right, coming to the androgenetic alopecia. Androgenetic alopecia, yes, definitely recommend and refer to a psychiatrist. Absolutely right. And if the trichobezoar is causing obstruction, then the patient is going to also need the surgical treatment. So androgenetic alopecia, we have this male pattern, Hamilton pattern, female Ludwig and Olsen pattern. So remember, in the male pattern, what is going to occur? There's going to be this Hamilton pattern where there's going to be this receding of the hairline and also vertex balding will be seen. And these patients, I commonly say that the usage of the face wash is going to increase and the usage of the shampoo is going to reduce a lot. In the female pattern, remember the anterior hairline is going to be spared and there's going to be thinning over the crown area. Crown area thinning will be there. And you can say this is a very classical frontotemporal hairline recession producing a Batman for you know, Batman. Treatment is going to be with the minoxidil, topical and also oral also are available nowadays. And finasteride, which is a type 2 alpha reductase inhibitor, thereby it is going to inhibit the testosterone conversion into the dihydrotestosterone. Testosterone is actually the reason for all the issues. That is the anagen hair is becoming very thin and shortened because of the DHT. Okay. Right. Next is non-scarring varieties. Again, you have this tinea capitis, which is going to produce this patchy type of this hair loss. Tinea capitis, remember black dot and gray patch, two types are there. So black dot variety is going to be the endothrix, which is going to enter inside the hair follicle, because of which hair will become weak. So it is appearing as broken hairs, which are appearing black dot like. And the organisms are very good. Yes, TB inside, gray dog outside. Absolutely right, Masudi. So tonsils, Trichophyton tonsils and violation. So these are TV which are going to be kept inside, that is endothrix. And this is the patchy hair loss. And remember, the tinea capitis is going to affect the children. So these are the important points to remember. Another type, gray patch variety, remember it's a ectothrix. So you can see again a patchy hair loss. And in this patch, you are seeing the gray color is there. The reason is because this organism, that is Microsporum canis, is going to coat the hair follicles. Ectothrix variety of tinea capitis. So that's why it is appearing like green color. So this gray colored dog, ferocious dog, is going to help you remember this is a gray patch variety. So coming to the alopecia areata, due to defect in this stage of hair cycle, remember it is the autoimmunity against the anagen hair follicles in the alopecia areata. So this picture, if it is given, what is the most likely diagnosis? It is alopecia areata, which you have to think of. Hypothyroid female presenting with patchy alopecia. Remember, the patchy alopecia areata can be associated with other autoimmune conditions. So hypothyroidism, Hashimoto's thyroidism, thyroiditis may be the autoimmune condition. So it is alopecia areata. 35-year-old complaints of hair loss and swarm of these appearances seen on histopathology. What is the most likely diagnosis? Is going to be alopecia areata, right? Middle-aged a patient, as you can see here, there is the development of this Batman-like shape. And what is this? This is a male pattern baldness. Male pattern baldness. Okay. Now coming to the glands. So which glands are going to open directly onto the skin surface without any association with the hair follicles? Can you remember what are those glands? So remember, they are the eccrine glands. So this is the eccrine sweat gland, which is going to open directly onto the skin surface. Okay. Right. Treatment for which condition you're asking? A treatment is usually not that much important to remember in the case of the whatever we discussed. Okay. Whatever is important for your exam point of view, I am trying to cover those. Okay. Right. Chalo. Now, these are the sebaceous glands which actually have to open along the hair follicle, but they at some places open directly onto the skin surface. We are going to call them as ectopic sebaceous glands. Can you remember the names of these sebaceous glands which are present over the lips? Tinea capitis is both scarring as well as non-scarring variety. Okay. Right. It is, yes, very good. It is Fordy spots. And this is over the prepuce. We are going to call it as Tyson's glands. It's called as Tyson's glands. And these are what are called as Montgomery tubercles. So all these are the examples for ectopic sebaceous glands. Montgomery tubercles. Okay. So disorders of the sweat glands, eccrine glands, if there is a blockage of the eccrine sweat duct, remember it's called as miliaria, or it's also called in Hindi called as khamoria, prickly heat, right? And in the apocrine glands, remember there could be this fox spot disease or apocrine miliaria. This is again due to the obstruction of the apocrine duct, and this is going to present as very, very, very itchy papules in the axilla areola and also in the groin, right? And in the case of the apocrine duct obstruction associated with a secondary bacterial infection, we are going to call it as hidradenitis suppurativa, which is going to present as erythematous tender nodules in the axilla and also in the groin. And these nodules will rupture to form the ulcers and they will heal with a very, very bad scar formation. So this is hidradenitis suppurativa because of the apocrine gland activity involvement. Next is acne vulgaris. Remember, this is a chronic inflammatory disease of not just the sebaceous gland but also of the hair follicle. So that's why we call both of them together as pilosebaceous unit problem, where polymorphic skin lesions can be seen. What are all those morphologies? So in the grade 1, so we are going to have the open comatones and also closed comatones. So these are the classical specific lesions for the acne. And we are going to see in the grade 2 the papular lesions, and in the grade 3 we are going to see the pustular lesions, and in the grade 4 we are going to see the nodules and cystic lesions. So that's why so many morphologies are seen. It's called as polymorphic condition. And what is the organism? It is a Cutibacterium acnes, or previously it was also called as Propionibacterium acnes. What is the treatment? Treatment is very important. Grade wise treatment should be remembered in the grade 1 because comedones are majority. Topical retinoids are going to be used as a treatment modality, which is going to consist of tretinoin and also adapalene. Remember, in the patients of acne, the retinoids are very important. So topical retinoids are going to be used in the first, second, and third grades and all of them. Whereas in the grade 4, we are going to use the oral retinoid, which is going to be isotretinoin. In the grade 2, we are going to add the topical antibiotic in these patients. Topical antibiotic will be added. What is the topical antibiotic which you are going to add? It could be nadifloxacin or it could be clindamycin. Coming to the grade 3, we are going to use the topical retinoid. Along with that, add the oral antibiotic. Oral antibiotic, we can add minocycline, azithromycin, and also doxycycline. You can remember any one of the MAD, minocycline, azithromycin, or doxycycline can be given to these patients. Now, related to isotretinoin, one more point you have to remember. What is the other name for this? It is also called as 13-cis retinoic acid. 13-cis retinoic acid. Okay. Next condition is acne rosacea. Remember, though acne is the term which is there in the disease name, it is actually rosacea. It is different from acne vulgaris. It is a chronic inflammatory facial dermatosis. It is going to affect mainly the centrofacial areas of the face. And because of the abnormal vascular activity in these patients, we are going to see the dilated blood vessels, which are called as telangiectasias, and erythema will be there over the cheeks. And if you remember, yes, the famous heroine Sai Pallavi actually has this rosacea condition. And these patients can also present with papules and pustular lesions over the face. But remember, comedones will be absent. Comedones will be absent in these patients. Comedones are absent. And if you see this type of very irregular nose or irregular chin or irregularly observed skin over the ears, you should remember it is a fibrous type of rosacea, and this is what is called as rhinophyma, this is what is called as gnathophyma, and this is what is called as otophyma. Right? So obliteration of the apocrine duct leads to Fox-Fordis disease. Fordis spots involve the sebaceous glands. Okay. And is it true that Fordis spots are seen over the lips most commonly? Yes, this statement is absolutely true. All of the following are true about Propionibacterium acnes except, so yes, can be found in the GI tract also. They are the normal flora and they cause acne vulgaris. So option C is the wrong statement. Sulfur granules is not related to acne vulgaris. Treatment of choice in the case of severe acne is the iso treatment, which is the oral retinoid. And what is the most common side effect of iso treatment? It is a cheilitis. What are the oral treatment options in the acne? Yes, it is doxycycline, minocycline, azithromycin, even as isotretinoin also. Which drug causes pigmentation of the skin? Remember, in the acne medications, minocycline can produce blue pigmentation of the acne scars. So acne fulminans is a severe form of acne. Apart from acne vulgaris, there are so many other types of acne, but the causative organism for this is also Propionibacterium acnes. So this lesion you are seeing in this patient of the age group 25 years, what is the diagnosis? So whenever you see the axilla presenting with these tender erythematous nodular lesions, think of the hidradenitis suppurativa. Think about hidradenitis suppurativa. Now coming to the nail topic. So important condition, nail psoriasis, which is going to be exactly opposite to that of the alopecia areata. So this is a patient of pitting, which you are seeing in the nail psoriasis. So where we are going to see the characteristic features of the pits being very, very deep in the nail, and also they are very, very irregular, and they are described as coarse pitting. Whereas if you see the alopecia areata patients, they are going to have very, very superficial pits, which are very, very regularly arranged, and they are very, very fine pits, which are seen over the nails. And if you see closely, the nail is going to have some substance which is present inside, in between the nail plate and the nail bed. This is what is called a subungual hyperkeratosis. And this subungual hyperkeratosis, it may sometimes lift the nail plate, which is going to cause what is called as onycholysis, separation of the nail plate from the nail bed. And one very important pathognomonic sign which you have to remember is the oil drop sign or salmon patch, which is pathognomonic of the nail psoriasis, and it is going to present clinically as yellow discoloration of the nail bed. And also in the patients of the psoriasis, there can be this thickening of the nail, which can also appear yellow in color in its entirety. So these are the questions which you have to remember. Oil drop sign is seen in the psoriasis. Coarse pitting of the nails is seen in psoriasis. Which nail finding is shown in this image? So you can see this material which is subungual hyperkeratosis. And this picture is actually showing you the small yellowish discoloration which is present in the nail bed. It is what is called as the salmon patch. And this is a histopath related question of the psoriasis. Munro's micropsis can be seen in the patients of the psoriasis on biopsy, which is nothing but the collection of the neutrophils which are present in the stratum corneum. Right. Now, pigmentary disorder. So, the picture which you are seeing here is the Becker's nevus. How can you identify this? This is going to present, the patients are going to present at the time of puberty. And what is, yeah, very good. Baker-Barber is a simple trick to remember this. So, Becker's nevus, the skin is going to be brown color associated with increased hair present only on one side unilaterally. It could be over the front or it could be over the back. Okay, so this is Becker's nevus. Very important point to remember as an image. Apart from this, the other pigmentary disorders are these three, which are dermal melanocytosis. The first one is a Mongolian spot presenting as blue colored skin present over the lumbosacral area, Mongolian spots. Next one is nevus of Ota, presenting as bluish discoloration of the skin or the face, and also you can see sclera is also appearing blue in color. Nevus of Ota. Next condition is nevus of Ito. Again, bluish discoloration is present over the back of the patient. Right? How to differentiate between Becker's nevus and nevus of Ito? Becker's nevus, Baker-Barber, so there will be hair growth here. So this is a Bahubali picture, which is going to help you to remember the blue colored bricks. So it is eat is the blue colored brick which you are seeing here. Nevus of Ito is bluish discoloration over the back. Some of the questions: a 22-year-old pregnant female presenting with this kind of hyperpigmented lesions over the cheeks. What is the diagnosis you are going to think of? It is melasma in pregnancy, which is called as cloasma. Sunscreen lotion has zinc oxide and also titanium dioxide. So both of these are physical sunscreen which you must remember. And this condition is integration with surgery and dermatology. Patient having melena, abdominal pain, and pigmentation of the lips. What is this syndrome called as? Yes, it is Peutz-Jeghers syndrome. Hamartomatous polyps are seen in the GI system. And if you see this type of a lesion, hyperpigmented macules present over the body or the photoprotected areas, you should think of the lentiginosis. And this is the very classical picture of the Becker's nevus. Over the back, you can see this brownish discoloration associated with the hair growth, overgrowth. And this is the nevus of Ota for you to identify the picture. And these are the hypo and depigmented conditions we are going to discuss. The first one is the albinism, which is due to the defect in the tyrosinase enzyme, because of which, though the melanocytes are absolutely normal, the patients are not going to have any pigmentation, and it could affect the eyes, ocular albinism, and it could also involve the skin and hair. We will call it as oculocutaneous albinism. Next is piebaldism. Here the problem is going to be with the neural crest cell function, because of which the melanocytes are not reaching the forehead and also over this forelock area, because of which is white forelock is produced in these children. And also apart from this, they are going to have the deep pigmented lesions over the body. But remember, they are going to be present from the birth. From the birth, these depigmented lesions will be present on the body, but forelock, white forelock is very important to diagnose the palbaldism, right? And this is the question: hypopigmented patches. What is that condition presenting as hypopigmented patches among the following options? So yes, it is nevus anemicus. Other than the nevus anemicus, rest of the all options are going to present as color. But nevus anemicus and also nevus depigmentosus, though the term nevus is there in them, they are not going to present as black lesions, but they are going to present as white colored lesions. And this is a patient, small depigmented lesion, and it's for 2 years from now. And what is the most likely diagnosis? So this is the picture, and it is a vitiligo vulgaris. And what is the treatment we are going to use? Routinely in the patients of vitiligo, it's going to be the light therapy, that is phototherapy. Among these two, if you have to select one, then NB-UVB is the better choice when compared to the PUVA therapy. PUVA therapy is Soralin with ultraviolet A rays, NBUV is narrow band ultraviolet B rays. And whenever this picture is given, very, very important, somehow AIMS examiner is very, very fond of this case, where there is going to be on one side unilaterally depigmentation in a segmental fashion. This is segmental vitiligo, which will be initially very, very progressive condition, but once that entire dermatome is involved, the condition is going to now become stabilized. And remember, the medical treatment modalities are not going to work in these patients. We are going to require some kind of surgery for this patient. So remember, segmental vitiligo, surgery is the treatment, and this condition is going to become stable. So yes, yes, yes. Next is psoriasis. So here remember, the most common type of psoriasis is psoriasis vulgaris, but this has other name for this. Is also called as chronic plaque psoriasis. What are the clinical features? You already know most of them. So erythematous scaly plaques, and what are these scales? They are described as silvery white scales, especially present on the extensor surfaces, as you can see here, over the knees and also the lumbosacral areas. And these patients also can have the arthritis, that is the distal interphalangeal joint involvement can also be there. And what is the treatment if there is arthritis? Especially methotrexate will be the treatment which is preferred, right? So Wickham stray, Masudi, it is associated with lichen planus. Please don't get confused. Okay, right. And these patients, they are going to have a problem that if they are started on the steroids and the steroids are suddenly stopped, then withdrawal of the steroids can produce these two types of severe forms of psoriasis, which are called as pustular psoriasis, where pustules will be there over the body, and also it could lead to the erythroderma, where the skin is going to become completely red, associated with more than 90% of the body surface area showing the scaling. Okay, so these are the adverse effects, or we can say the complications of withdrawing the steroids, oral steroids. Okay, withdrawal of the oral steroids in a psoriasis patient. Remember, to diagnose this, we have a biopsy, but before that, bedside, what is a simple test? Which sign which we can do is the Auspit sign, in which we are going to take a glass lid and we are going to scrape the lesion. The scraping is going to give the gratification for the dermatologist. So this is what is called as a grattage test. I hope you remember this from the movie Spider. So gratification, so that grattage test. But once we start this, what is going to happen? The scaling is going to become more and more prominent. And once it is going to become more and more prominent, ultimately we are going to see the bulkous membrane. This membrane, if it is completely removed, then ultimately we are going to see the pinpoint bleeding spots, and these pinpoint bleeding spots is the end point for the Auspit sign. Very, 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 very important. It's asked so many times, you have to remember this. And along with this, few points to remember: Auspit sign could be negative in some special types of psoriasis, which are PIG, pustular psoriasis, inverse psoriasis. Pustular, you already know. Inverse psoriasis is psoriasis if it is present over the flexural surfaces, it is called as inverse psoriasis. Right. Next one is the G. G stands for guttate psoriasis. So these three conditions may have Auspit sign negative. Right. Okay. Coming to the histopathological finding in the psoriasis. So if you look at the stratum corneum, you already know there's going to be thickening of the stratum corneum, hyperkeratosis, persistence of the nucleus, parakeratosis. You already know this point also. Neutrophilic collection in the stratum corneum is called as Munro's microabscess. And stratum granulosum may be absent if you do a biopsy in this psoriasis patients. Stratum spinosum can also have this collection of the neutrophils, and this collection of neutrophils is now called as spongiform pustules of Kogoch. Spongiform pustules of Kogoch. And also you can see the dermal papillae, they are going to consist of this dilated blood vessels, blood vessels. And in fact, these blood vessels are the reason for the clinical auspit sign. Clinically, auspit sign is seen because of the bleeding coming out through these dermal blood vessels when we are rupturing, removing the scales. Now coming to this, identify this psoriasis where you are seeing this raindrop like papular lesions. This is gutted psoriasis, which is seen in the children associated with group A beta hemolytic streptococcus, because this is associated with the infection. So the treatment here is going to be with macrolide antibiotics. So it is very different in a treatment fashion. Okay. Sausage digits you can see in the patients of psoriatic arthritis. Auspitsen is seen, psoriasis vulgaris, you already know that. And in the shown picture, the scratching leads to bleeding followed by further formation of similar lesions. What is this suggestive of? Yes, it is suggestive of psoriasis vulgaris. And what is this appearance of the similar looking lesions in a linear pattern? What is it called as? Yes, it is what is called as Koebner's isomorphic phenomenon. Koebner's isomorphic phenomenon, which can be seen not only in the psoriasis, but also in the case of the lichen planus and also in the case of vitiligo. But yes, it is not seen in the patients of the herpes. It's not seen in the patients of herpes. PSLV is a simple mnemonic to remember the causes for the Koebner's phenomenon. Koebner's phenomenon. Coming to the drug of choice, methotrexate is a drug of choice for the patients of psoriasis vulgaris, apart from the psoriatic arthritis and also erythrodermic psoriasis. Acetretin is the drug of choice for the patients of pustular psoriasis. And remember the concept behind the isotretinoin. Whenever we start isotretinoin and also acetretin, both of them are retinoids, oral retinoids. The woman should not become pregnant, and the washout period in the case of isotretinoin will be for a period of at least 3 months, 1 month to 3 months. And in the case of acetretin, the woman should not become pregnant because these are teratogenic for a period of whooping 3 years, right? And remember, if the patient is having this pustular psoriasis in the pregnancy, it is what is called as hepatic herpetiformis and also psoriatic erythroderma in pregnancy. In these two cases, we cannot use the methotrexate or the retinoid. So we are going to use the steroids. So they are going to be the drug of choice in these patients. Okay. So next is lichen planus. So remember in this lichen planus, we are having so many P's. So they are going to be plain topped purple papules, plaques, which are going to be present over the plexural surface, plexors, that is flexural surfaces, and they are purple in color, violaceous. Okay. So these are all the P's which you have to remember. Apart from this, these patients are going to have this network like lacy pattern over the skin and also in the mucosa, which is called as Wickham striae, as you can see here. And very important association to remember with the lichen planus is what is this? This is the amalgam, which is going to consist of the mercury. And also remember, the lichen planus patients can also have the association with the hepatitis C virus. Very, very important recent question. Hepatitis C virus could be one important association. And if you see the nails of these patients, you can clearly see this wing-shaped pterygium formation, which is very classical. Pterygium nails can be seen in this lichen planus patient. And if you do a biopsy, what are the changes which you are going to see in the stratum corneum? Thickening of the stratum corneum, which is called as hyperkeratosis, can be seen. And these patients are going to have thickening of the stratum granulosum layer. Hypergranulosis will be seen. And if you look at the dermatopathology junction, there will be lymphocytes present here, lymphocytic infiltration, which is called as band-like lymphocytic infiltrate, which is going to cause damage to the dermoepidermal junction. The retail ridges. Because of the retail ridges are going to become sharp, and these are what are called as sawtooth retail ridges. Sawtooth retail ridges, as you can see in this picture, the sawtooth thing of the retail ridges. And if you further see, they are going to also see that there are going to be some species which are produced at the dermoepidermal junction because of the damage of the stratum basal layer. This is what is called as a Max Joseph space. Max Joseph space. And we can also see the apoptosis of the keratinocytes, which are what are called as civate bodies. These are also called as colloid bodies. They are also called as colloid bodies. Okay. So this is how the picture may be given by the examiner. So where violaceous lesions are present over the plexural brist area, lichen planus, Wickham stray can be seen in lichen planus. Okay, and this picture, this is the picture which the examiner gave you. This is pterygium of the nail, and this is how the clinical pigment may be given. Old female, 30-year-old female, lacy lesions in the oral cavity, Wickham stray, even in the genitals they can be present. So proximal nail fold has extended onto the nail bed. This is the description of the pterygium which is mentioned. So what is the diagnosis? Yes, it is going to be the lichen planus in this case. Pityriasis rosea, you can very easily remember with the help of Virat Kohli and also MS Dhoni. So MS Dhoni and Virat Kohli are wearing their mother's names. That will help you to remember that mother patch can be seen in this patients, which is also called as herald patch, and you can see they are having a collar. So collarate scale will be seen in this mother herald patch, and the daughter lesions are going to present over the body, and just like the Christmas tree pattern can be remembered. And both these players are actually taking a rose flower, and they are going to the pavilion to give this rose flower to the mother and also to the wife. Okay, so with the help of that, you can remember the rosea, Pityriasis rosea. So I pity these two because if they give to the wife alone, then mother is going to get angry, and if they give to the rose flower to the mother alone, then wife is going to get angry. So my suggestion would be take two rose flowers, give them to both of them. And yes, very good. The causative organism is the human herpes virus number 7, which can be remembered with the help of this jersey number of Dhoni. So this is Pityriasis rosea for you. Next, this are the questions which will be asked. Lacy lesions in the oral cavity. So this we have already discussed. Band-like lymphocytic infiltrate. Okay, it is not HSV7, it is HV7. Okay, one student wrote it as HSV7, it is HHV, human herpes virus. Right, okay. So auto-thing of reiterates, it's a histopathological feature of lichen planus. And if you have to identify this herald patch, which is having the small daughter lesions, so you should think of Pityriasis rosea. So all are true about the image, except what is the exception here? HHV7 is a positive agent, absolutely right. It is Pityriasis rosea picture. Herald patch is seen, absolutely right. Heal spontaneously, perfectly right. Remember, it is not predominantly seen over the genital, it is predominantly seen over the trunk. Annular herald patch, Pityriasis rosea, Christmas tree pattern, Pityriasis. So these are some of the one-liners which could be combined together and they can be asked as a clinical question. So be aware of this. So next is this bacterial infections topic. We are going to see very important bacterial infections from exam point of view. First, so I hope all of you are able to follow and this speed is okay. And shall we take just a 1 minute of silence break because it is 1 hour after the session. Okay. So just 1 minute of simple silence. We are going to again start back. So if we finish early, you can take a long break. Okay, that's why we are just having a small 1 minute break. We are again going to come back at 9 o'clock. So, chalo students, we'll restart. Okay. Chalo. J.E. Balaya. Yes. Okay. So, non-bullous impetigo, it is also called as impetigo contagious. So, what is etiological agent for this? It could be both staphylococcus or it could be also streptococcus. Whereas bullous impetigo, remember, the only and only causative organism is always going to be Staphylococcus aureus. Staphylococcus aureus, 70 and 71 strains, and it's going to be the exfoliative toxin A toxin, which we have already discussed in the case of the staphylococcal scarlet skin syndrome, if you remember. And in the case of bullous impetigo, remember the very important crust which will be formed, which is called as honey colored crust. Honey colored crust. Okay. Next is erysipelas. Erysipelas and also cellulitis. So erysipelas, Saint Anthony's fire. Remember the involvement is going to the upper half of the dermis, and in the case of the cellulitis, it's going to lower half of the dermis, and along with that, there can be also subcutaneous tissue which can be infected. And remember, erysipelas only causative organism is group A beta hemolytic streptococcus, whereas in cellulitis it could be both staph and also strep. And in this, because it is very, very superficial, so the margins are going to be well-defined margins clinically. And in cellulitis, they're going to be very, very ill-defined margins. Very important points to remember. And especially this is a very, very important PYQ to remember. Erythema around the nail fold associated with the pus collection and very painful condition. This is acute paronychia. And here you can see the pus. And what is the treatment of this? Because it's a bacterial infection, is going to be the antibiotics which will be needed. If there's a lot of pus is there, then incision and drainage may be required. Acute paronychia. And remember, there is one more chronic paronychia in which the patients are going to have the same clinical picture, but it is going to be presenting very, very chronically since few months. And the important causative organism here is going to be the Candida. Here it is Candida. Okay. Some corynebacterial infections. The first one is erythrasma, which is because of the Corynebacterium minutissimum, which is going to present with the lesion, which is going to be hyperpigmented or skin colored asymptomatic lesion which is present usually in the axilla and also in the groin. What is the investigation which is going to help to diagnose? It's a wood slump examination which will reveal the coral red fluorescence or coral pink fluorescence presenting in the axilla or wherever this condition is going to affect. Few points related to the wood slump which you have to remember. The wavelength of this light is going to be 365 nanometers. 365 nanometers, and it is useful in various conditions, like for example in tinea capitis because of the microsporum and also in the Trichophyton schonleni we can see this blue green dull blue fluorescence. P. versicolor is going to show the yellow fluorescence, and in vitiligo we are going to see this milky white fluorescence. Milky white fluorescence can be seen. And this is a patient of the P. versicolor with yellowish fluorescence. And this is a vitiligo where the already pre-existing depigmented lesion is going to become more and more white in color after the wood slump examination. So can you identify this picture where you are able to see multiple discharging sinuses pus points? So that is a carbuncle. That is a carbuncle. And this picture is very classically showing the honey colored crusting. So this is impetigo contagiosa or the non-bullous impetigo. And in the patients of the non-bullous impetigo, what is the very important complication which you have to remember? Because in these patients, streptococcal infection could also be a cause. So post-streptococcal glomerular nephritis, PSGN, is one very important complication which you have to remember. And this is a patient who is having this type of a well-defined lesion on the face, well-defined margins are there, and it is an infection with group A beta hemolytic streptococcus, which is producing this very classical picture of erysipelas or Saint Anthony's fire. So this is how the questions can be asked, right? And this is a child, infant, whenever the examiner mentions presenting with this peeling off of the skin after any focus of infection, you must first think about staphylococcal scarlet skin syndrome in those infants, children. Okay. And this is a patient who's having nail fold, which are erythematous. Just now we have seen the pus collection. This is paronychia. This is a very important image-based question. Remember, dear students, don't expect the previous year questions to be just repeated verbatim. They may, ask the next level of question. Like for example, Till now, in few years, since years, they were asking about mycetoma, but previous year they have asked what could be the treatment of the mycetoma. So likewise, so now they are asking you about simply paronychia. Next exam, they may ask you whether this is acute paronychia or chronic paronychia. So likewise, you should be ready that the examiner may ask you not different topic altogether, but the extension of the previous topics which you have read. Okay. Okay. So now this is erythrasma, which is caused by the Corynebacter minutissimum. On wood slump examination, it is going to show coral red fluorescence. Okay. So this is fungal infection which we are going to discuss, Pityriasis versicolor, Pityriasis versicolor, and it is called versicolor because it's going to present as versatile, it's going to have versatility. So it can be hyperpigmented or it can be hyperpigmented. Pityriasis, whenever you hear that term, remember it's associated with scaling, and the etiology is going to be with Malassezia globosa, Malassezia furfur, any one of them. And if you're not able to see the scaling very clearly, then what you can do is you can scratch the skin when the scaling is going to become prominent. Especially remember, whenever we have any contact with other individuals, we always try to say that don't scratch others. Evarni gokaddu. But in this case, we have to do that to diagnose this condition. So in the investigations, remember, you might have heard this KOH mode, KOH potassium hydroxide is going to dissolve the keratin, where we are going to see the short hyphae and round spores as a combination. This is what is called as a spaghetti and meatball appearance. Spaghetti meatball appearance. On wood slump examination, we are going to see the yellow fluorescence. Yellow fluorescence, right? So this is the patient hyperpigmented macules over the upper back, KOH, spaghetti meatball appearance is seen. What is the diagnosis? It is Pityriasis versicolor and Malassezia furfur, right? Pityriasis, Malassezia globosa, Malassezia furfur. So wood slump examination can be used for the diagnosis of this Pityriasis versicolor. We can also use the other KOH also, apart from wood slump. So what will be the treatment of choice in these patients? Is going to the topical azoles. We can use topical ketoconazole as an application. And the simple trick to remember this Pityriasis versicolor is, Brad Pitt is a versatile actor. Brad Pitt is a versatile actor. And I pity Brad Pitt because Angelina Jolie and Brad Pitt were a pair and they have separated. So I feel pity for Brad Pitt and he's a versatile actor. So this will help you to remember the spaghetti meatball appearance with this image where the Brad Pitt is eating the spaghetti meatball over the yellow table. So yellow fluorescence can be seen on wood slump examination. So this is just a way to remember this. Next is tinea capitis. One patient, patient of tinea capitis, they are going to be children, and there could be the non-scarring type of alopecia, which is black dot gray patch. Apart from the two types, we are also having another two types of tinea capitis where there is going to be scarring alopecia, Chiron favors. Chiron, the causative organism, is zoophilic fungi. So the examiner may mention the association with the pets which are present in the house. And etiological agents are Trichophyton verrucosum and Trichophyton mentagrophytes. And clinically, how is it going to present? The patients, children are going to present with boggy, indurated swelling over the scalp, easily pluckable hair with crusting can be seen, and there can be regional lymphadenopathy in these patients. And investigation KOH, if you do, you can identify the fungal hyphae. And this is the boggy swelling which you can see here, and this is going to produce the permanent hair loss, scarring alopecia. That's why treatment, early diagnosis and treatment are very important. Coming to the favors, remember you can change the name to fivers because fivers looks like five, and in this they are going to have some yes in the disease. Trichophyton Sean-Lenny is the causative organism. Yellow colored crust, cup-shaped crust, which are present, they are called as scutula. So yes for scutula, yes for Sean-Lenny, and yes for fivers. So that way you can remember the important points related to the fivers. So these are the cup-shaped structures, crusts, which are yellow in color. Coming to the steroid, if they are applied over the tinea lesions, tinea corporis over the body, tinea cruris in the groin, so it can lead to the tinea incognito, because we cannot diagnose this patient because itching will reduce, inflammation will also reduce. But these patients are going to have one very important symptom, or we can say observation, that the lesions are going to be very, very scaly lesions, right? Candida of the oral mucosa, that is tongue, it is called as the oral thrush. Oral thrush, and it's going to present as a whitish membrane, which can be easily removed with the, which can be easily scraped off. Right. All the following are true for the image except so. Yes, this is the Tinea cruris, which is also called as Dobich, jock itch. Okay, and it is common in the tropics, and it is not caused by Candida, but it is caused by Trichophyton dermatophytes. Patient with boggy swelling, what is the possible diagnosis? Yes, it is Tinea capitis. Specifically, if you have to ask what is the type, it is Kerion. You have to remember. Tinea corporis gladiatorum is going to involve the trunk. Trunk is going to be the site of involvement. Okay. Okay. 20-year-old patient present with extremely itchy lesion, and in this picture you are seeing that one annular lesion is present in the another annular lesion. So this is special type of tinea which is called as tinea imbricata, which is because of Trichophyton concentricum. The positive organism is Trichophyton concentricum. Concentric rings will be there in these patients. Now coming to the subcutaneous mycoses, these are also called as implantation mycoses, and the very important clue which the examiner is going to give you in these mycoses is going to be the formation, the prick with a thorn or any sharp object, after which if there is development of this linear lesions, nodular ulcerative lesions along the lymphatics, then you should think of the sporotrichosis, which is also called as the rose gardener's disease. Rose gardener's disease. Causative organism is sporothic shinki. Sporothic shinki is a causative organism, right? And if you happen to see the verrucous lesion at the site of the trauma, then it is verrucous dermatitis, also called as chromoblastomycosis, because these are produced by the pigmented fungi, and the investigation is going to be 10% KOH, which is going to show the copper penny bodies or medlar bodies or muriform bodies as sclerotic bodies. Very important from micro and also the dermatology. Next condition is after the thorn prick, if there is mycetoma, how is the presentation clinically going to be? There's going to be the triad of the tumefaction, that is swelling of the feet will be there, sinus tracts will be there, and these sinus tracts is going to be granules. And what is the color of these granules? In the case of bacterial actinomycetoma, the color will be pale, whereas in the case of fungal eumycetoma, they are going to be dark or black in color. And what are the causative organisms? In the case of eumycetoma, Madurella mystomatis and Madurella grigia are the causative agents. In the bacteria, Actinomycetoma madure, Nocardia brasiliensis, Streptomyces, somaliensis are the causative agents. Right? And this is a very, very, very important question which the examiner is asking you. You can remember with the help of RGV. RGV wrote one book, My Wish, My Wish. Okay, so mycetoma, and he has made a movie also, that is the GST. Okay, that will help you to remember the triad of the features, and also remember the granules. What is the color of the granules that is going to decide what is the answer for the question. So this is a dark granule. This is eumycetoma. So students, whenever I give this movie name or any other clues or mnemonics or tricks, what their students are going to tell is, you are dark, sir. That's what students are going to tell. So it's okay. Yeah, it's okay. So even if you think like that, I'm fine. You, if you feel that I'm dark, it is okay. But still, eumycetoma is the one which is going to show the dark colored granules. If that will help you to remember the mnemonic or trick, I'm okay for that. Right. Next is a patient coming from Himachal Pradesh. Thorn prick and subsequent presence of verrucous lesion. The diagnosis is. So now tell me what is the answer for this question. Thorn prick is there. So should we answer sporotrichosis as the answer? No, verrucous lesion. Verrucous lesion. So it cannot be sporotrichosis. Be very careful. What happened is not important. Now, what is happening after what happened is what is very important. So, verrucous lesion is developing. So, it is chromoblastomycosis. So, be very careful with this type of questions. Very, very easy looking, difficult question. Okay, if you do this type of mistake, it is going to be a silly mistake, but after the examination, this 1 mark also may be very, very heavy on you. So be very careful. consider every MCQ as 150th MCQ. Okay, don't try for 150 marks. Then you are going to do great in the examination. Okay, don't worry. These type of mistakes you have to observe and identify now itself. And this is a picture. Okay, previously we have already seen that. Okay. All right. Chalo. Now next, viral infections. So herpes simplex virus HSV1 is going to produce the grouped vesicular lesions present near the lips. This is what is called as the orolabal herpes or fever blisters. Right, and VZV, this is going to be discussed by Anand sir very clearly, very depth in pediatrics. So we are not going to go into the details of this. So rose petal, dew drops. So all this is okay. Okay, now these are the questions which dermatology is going to ask you. Bangkok, the patient is present with perioral vesicle. So what is the diagnosis you are going to think of? Herpes simplex. Okay, so Bangkok, truck drivers, these are the ones which are going to be associated with sexually transmitted conditions. Chickenpox rash, all are true except, so what do you think is wrong here? So yes, it is superficial, yes, it is centripetal, and the lash is pleomorphic, but palms and soles are spared and but not involved. Okay, child fever lesions are one stage after the other. That is pleomorphism is what is described here. So it is chickenpox. It is chickenpox. So these are the questions which can be asked. Very important, viral infections from dermatology point of view, multiple painful blisters for the trunk, following a dermatome, grouped vesicles. What is the diagnosis? Very good. It is shingles herpes zoster. So what is not correct about this picture? What is wrong about this picture? Lesions are infected with seronegative individuals. Absolutely correct statement. Can be associated with meningoencephalitis. Absolutely correct statement. Geniculate ganglion is involved in Ramsay syndrome. Also correct statement. Remember, it is unilateral but not bilateral. It's symmetrical. And this picture, please don't see that it is some kind of a position. It is telling you that the thoracic dermatome is the most common dermatome which is affected in the herpes zoster. Treatment is with antivirals, val acyclovir. Right? Molluscum contagiosum. What is the causative organism for molluscum contagiosum? Right, it is the pox virus, and the pox virus is molluscum contagiosum virus. And in the children and also in the adults, the molluscum contagiosum can produce this lesions. And in the children, remember, it's going to present very classically as pearly white dome shaped umbilicated papules which are present over the face. And in the children, there could be a mention of the mother and siblings having similar lesions. Yes, very good. We can see on biopsy, HP bodies, Henderson Patterson bodies can be seen in these patients. Coming to the warts because of the HPV, human papilloma viral infection, they could be genital, when we call them as condyloma acuminata, and if they are non-genital, we have various subtypes of the HPV which can produce most commonly the verruca vulgaris, as which presenting as a rough or uneven surface over the skin, right? And we have various types of the warts, which you can remember: DSP, deep plantar warts, superficial plantar warts, and verruca plana, which are DSP produced by the HPV subtype 1, 2, and 3. And common warts are commonly called as wart, which has 4 alphabets, so it is HPV subtype 4. And larynx is associated with LARYNX, 6 alphabets are there, HPV subtype 6. And butcher, those who are handling the meat, so in them the number of alphabets in the butcher again 7. So HPV subtype 7 is producing butcher's warts, right? And what are the treatment options? Salicylic acid, cautery, and cryotherapy. These are the different treatment options for different patients. Next, enteroviral infections. The most important one to remember is the hand, foot, mouth disease, in which patients usually are going to be the children having lesions of the hand, foot, and also in the mouth. Mouth will show erosions. Hand and feet are going to show this papillovesicular lesions. And what are the etiological factors? They are the enteroviruses, that is Coxsackie virus A6, A16, and also enterovirus number 71. So these are the points related to hand, foot, mouth disease, which are very important for you to remember. Next is condyloma acuminata. Condyloma acuminata. Acuminata is pointed and it is associated with HPV infection. In the genitals, you can see this rough surfaced cauliflower-like lesions, which are called as condyloma acuminata. Right? And remember one very important image-based question which was previously asked, where we are going to see at the coronal sulcus if there are small papules. Okay, and these papules, they are not present on the glans penis or other areas of the prepuce. What is the diagnosis for this case? Very good, Adhya. So it is pearly penile papules, but not warts. Okay, so these are pearly penile papules which are not related to HPV, which are not related to HPV, and this is very important image based question which was asked previously. So you should be able to identify this by the image also. How to differentiate between the viral warts producing the condyloma acuminata? So in the warts, we are going to see the involvement of the glans penis. Lesions will be seen on the glans penis also, right? Next is the genital discharge disease, which could be gonococcal urethritis or it could be non-gonococcal urethritis. Gonococcal urethritis, obviously, it's going to be Neisseria gonorrhea. Is the voice low or is it okay for everyone? If you're having any difficulty with the voice, please once go back and come back. I think there is some issue with the app or in the phone. Okay, but others are okay with the voice. Right. Okay. So non-gonococcal urethritis, what is the most common causative organism? So remember, it is going to be the Chlamydia trachomatis. Chlamydia trachomatis. And remember, the gonococcal urethritis patients are going to have the very, very severe symptoms: fever, arthralgia, myalgia, body pain, severe pain, and also very, very painful urethral discharge will be there. And this is going to be very, very painful, and frank pus is going to come out through the urethra. And if you do a gram stain, what is going to be observed? We are going to observe this gram negative diplococcal, very classical for gonococcal infections, can be seen. Coming to non-gonococcal urethritis, patients are going to have scanty mucoid urethral discharge. And if you do a gram stain, we are not going to see any gram negative diplococci. What is the treatment? Treatment is very important. In the case of gonococcal urethritis, injection ceftriaxone is used for the treatment. Whereas if it is a diagnosed case of non-gonococcal urethritis, then we are going to use the doxycycline as a treatment. And remember one more point, if the patient of gonococcal urethritis, if we cannot rule out the non-gonococcal urethritis, then we should also give these patients doxycycline to cover the non-gonococcal urethritis. To cover non-gonococcal urethritis. Okay, important point to remember. Next, we are going to see the syphilis, acquired syphilis. So remember, the patients after the unprotected sexual exposure, there is going to be this single clean based ulcer, which is going to be very, very painless, but very, very hard to feel. That is indurated ulcer, and it is not going to bleed on touch because it is indurated. So that's why it is also called as hard chancre. And remember, the name of this disease, you can change it to, instead of syphilis, you can remember it as syphilis. Reason? Because the ulcer as well as the lymph node both are absolutely painless. So that's why you can remember it as syphilis. Rubbery consistency of the lymph node will be there. And if you do a dark ground dark field microscopy, in this we are going to see the presence of this corkscrew motility of the Treponema pallidum. And if we don't treat this condition, what is the treatment? Usually with injection benzoyl penicillin. If we don't treat, then these patients are going to go into the next stage, which is called as secondary syphilis, in which case the patients are going to have the involvement of the mucosa in the form of these broad moist lesions, which are called as, remember, condyloma, not acuminata, but here these are lata. So just remember, you can add the alphabet F here to make it condyloma flata. So these lesions are going to be moist and flat lesions. Okay. And they are also going to have these hyperpigmented lesions over the palms and the soles. Very, very important. These are what are called as syphilids, which are again classical finding of secondary syphilis, syphilids. Chancroid is produced by the Haemophilus ducreyi, and this crying crow is going to help you to remember all the features of the chancroid. So remember the Haemophilus ducreyi, the patients are going to cry because the ulcer as well as lymphadenopathy both are very, very painful in these patients. So lymph nodes are also, painful, and also the ulcer is also going to be very, very painful. But unlike the syphilitic chancre, this is going to be very, very soft. So this is also called as soft sore. And there are going to be multiple ulcers which are present over the genitalia, right? And also it's going to bleed on touch. How can I remember that? Because it is hemophilus, blood loving, so it will bleed on touch. And in the patients of Shankar, we are going to see this enlarged pus-filled lymph nodes, and these are what are called as bubo. Remember, bubo can also be seen in the patients of the LGV along with Shankar, right? Investigation, if you do a gram stain, gram negative cocobacilli are going to be visualized, which are going to be arranged in a long parallel strand. These are what are called as the school of fish appearance, school of fish appearance, or railroad track appearance, railroad track appearance. What's the treatment which you are going to use? It's going to be with azithromycin, which is a topic, which is a oral macrolide, azithromycin. Azithromycin will be used. How can you remember all this? With the help of this crow and fish story. So this crow is crying. The reason is because it wanted to eat the fish, but it is not able to eat the fish. That's why it has, gone to the railroad and it has committed suicide. It has died. That is the story of a old crow, but we have a new crow here, Gemini Grok. So this is the latest crow, Claude using crow. So it knows the test tube is having the fish, and also it has water. So what it is going to do, it is going to throw the stones and it is going to eat the fish, and also it is going to drink the water. So this is the modern crow, which is I want all my students to be like this modern crow, which are very very problem solving and very very fast developing, and they are going to convert the difficulties into the opportunity. So this will help you to remember the features of the chancroid, and also you can remember the treatment macrolide and chancroid, or you can remember azithromycin as a drug. Okay, next is genital herpes. Genital herpes, remember, it is HSV2 which is producing this genital herpes in the form of the multiple grouped vesicles present over the genitalia, which are going to ultimately rupture to form the erosions. And in these patients, if you observe the lymph nodes, they are going to be very very painful lymph nodes. But remember, no bubo will be seen in these patients. And even in these herpes genitalis patients, the ulcer and also the lymph node both are very very painful. Both ulcer and lymph node are painful. And if you do a Zank smear as a cytodiagnostic test, what are the cells which you are going to see here? We are going to see the acantholytic cells, and also we can see what are the other cells which you can see. Multinucleated germ cells can also be seen. And the treatment which you are going to use is going to be the acyclovir, which is used as a treatment. Acyclovir for a period of 1 week, 400 mg TID will be given. And remember, no partner treatment is needed in the case of the herpes genitalis. And along with that, we are also going to have two more conditions, which are candida and bacterial vaginosis, in which no partner treatment is required if the partner is asymptomatic. If the partner is asymptomatic. Donovanosis, granuloma inguinal, granuloma venereum. What is the causative organism? It is Klebsiella granulomatis. Klebsiella granulomatis. And here we are going to see the beefy red, very, very beefy red ulcer because of the exuberant granulation tissue. And it is going to bleed very, very easily on touch. And if you observe the lymph nodes are absent. So that's why we are going to call it as pseudobubo. Pseudobubo. And if you do a crust tissue smear, we are going to see the pund cells which are having these closed safety pin appearance, which are nothing but the Donovan bodies. Closed safety pin appearance, which are nothing but the Donovan bodies. Donovan bodies. Okay. Lymphogranuloma venereum, again you can remember this with the help of RGV, LGV. Causative organism is Chlamydia trachomatis. And here the initial genital lesion may be unnoticed, and second stage may be the one which a patient presents with, which is a bubo, which is going to present with this classical groove sign of the Grenblatt. So here this sign is very important, groove sign of Grenblatt. And the third stage, there is going to be deformities of the genitalia. That is the reason is because of the obstruction of the genital lymphatics. So deformities will be there. Treatment will be with Doxycycline. Again, this can be remembered with the help of the RGB. So you can see RGB in the new avatar. So RGB likes the media attention. So chlamydia can be remembered. So whenever RGB makes any interview, the groove sign tararara, pap, 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 is going to be played. So that will help you to remember the groove sign. And also these patients are going to have the elephantiasis and also saxophone penis. So please just imagine the RGB playing this saxophone. And also he made a movie called as Shiva, in which there was a cycle chain fight. So that will help you to remember the treatment of these patients with the help of doxycycline. Not only that, even he is against one political party, which is Telugu Desam party. The uh, symbol for this party is cycle. So RJ was having so much of animosity with this party. So he made so many derogatory comments. So that will also help you to remember that treatment is with doxycycline. So RGB is going to help you to remember all the features of LGB. So now coming to the diagnosis of this genital ulcer disease. So ulcers, if they are present, see if they are multiple painful ulcers. There are two possibilities. It could be chancroid or it could be the herpes genitalis. So if the patients are having painful lymphadenopathy which has a bubo, so then the diagnosis is chancroid, and this is herpes genitalis. Okay, next is single painless ulcer with bilateral painless lymphadenopathy. Painless ulcer, painless lymphadenopathy, it is syphilis. Painless ulcer is there and there's no lymphadenopathy. It is, what is this? Donovanosis. And painful bubo is there and single painless genital ulcer. What is the diagnosis here? It is LG. So very, 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 very simple way. You can just look at this flow chart and you can easily diagnose the genital ulcer diseases. Okay, next is what is not due to HPV. So option B, that is the condyloma lata, is because of secondary syphilis but not HPV. A male presented urethral discharge to the clinic. Which color coded kit should be provided to him? So we are going to see the mnemonic. It is gray colored kit, which is a kit number 1. Kit number 1. Okay. Adult male presented for intercourse button like indurated painless ulcer, painless lymphadenopathy. What is the diagnosis in this case? It is syphilis. Syphilis. Right, truck driver STD is the one which you have to think of. Painless lesion on the penis, skin rashes as seen. So remember, painless lesion on the penis probably is the primary syphilis, followed by the skin rash. When skin rash is present, syphilids are present. You should think of the secondary syphilis. Secondary syphilis. And young female asymptomatic macules and papules of the trunk, reddish patch or the palate, moist lesion on the vulva, generalized lymphadenopathy is there. What is the line of the management? Remember, asymptomatic macules, papules or the trunk, and reddish patches over the palate, and moist lesion on the vulva. So this with the along with the skin lesions, it is talking about secondary syphilis, and this moist lesion is nothing but the condyloma lata. And these patients are secondary syphilis. So this is a case of secondary syphilis. They can have this generalized lymphadenopathy. Treatment is with injection penicillin. Absolutely correct. Very good. Painful ulcer on the glans penis can be seen in the case of the chancroid. Painful ulcer can also be seen in the case of herpes genitalis also. Multiple bleeding painful ulcers can be seen in the case of painful ulcers can be seen in the case of chancroid and also herpes, but bleeding painful ulcers, hemophilus do cry do hemophilus. So chancroid is going to bleed. Groove sign can be seen in LGV. Remember RGV and LGV, right? So these are some of the other symbols which you have to remember. Apart from this, this is a symbol for which one? So yes, very good. It is Suraksha Clinic. So you can just imagine this patient, male or a female, with the trunk and the extremities, the upper extremities, and these are the genitalia which are shown with the help of the red dot. That will help you to remember that it is related to the STDs, Suraksha Clinic. And these are the NACO kits, which are again very important for you to remember. Salmon Bhai is going to help you to remember the order of the NACO kits. So, gray girl wearing bracelet reading yellow book. Gray girl wearing bracelet. So, don't worry reading yellow book by looking at this table. It might look very difficult, but it is very easy. I will tell you how. So gray girl, so that is 1, 2, 3, 4, 5, 6, 7. Dosage is not much important, but at least drugs and the color and the kit number, these are important. So kit numbers you can remember with gray girl wearing bracelet reading yellow book. So grey colored kit number 1, ये मुंबई शहर को पेशाब करवाने आया हूँ मैं. So grey colored kit is going to be used in urethral discharge, so which should consist of the medication which will take care of the gonococcus and the non-gonococcal infections. So obviously it's going to consist of cefixime 10 mg and azithromycin to take care cefixime to this azithromycin to take care of the non-gonococcal hepatitis. Okay, kit number 2 is for vaginal discharge, in which you are going to have obviously to cover both the infections because of candida and also bacterial vaginosis and trichomonas vaginalis. So we are going to secnidazole and fluconazole. Kit number 3 and 4 are used in the patients of, you can remember, syphilis and the chancroid. So to cover the syphilis, to treat the syphilis, benzoyl penicillin will be there, and for the chancroid, we are going to have this azithromycin. So if the patient is having allergy to penicillin, then we are going to replace the penicillin with doxycycline. Doxycycline, azithromycin will be the same. Kit number 5 is for herpes genitalis. 5 is for herpes genitalis. Kit number 6, you might have heard in your OBS gynae. OBS gynae, it is used in the case of pelvic inflammatory disease. So 3 medications should be used: metronidazole, cefixime, and doxycycline. Kit number 7 is used in the case of the LGV, which is going to be doxycycline. You already know this. And kit number 8 is a recent addition. It is a color is brown color. Literally, it is anorectal discharge. So it is going to be brown in color. So it is having the same color, and it is because of the male sex male MSM. So urethral discharge organisms produce this condition. That is the reason why the medications are going to be the same, except for see, cefixime is the same as kit number 1. If you observe carefully, here also cefixime is there, but instead of azithromycin, we are here using doxycycline because it is difficult to treat condition. So it is doxycycline, right? So this is how you can, broadly remember the kits. Very, very important, we can say, because since few times the treatment is not being asked, but definitely STDs MCQs are being asked, but treatment related, it has been so many days. So maybe examiner may somehow ask you about treatment. So check it out. So next we are going to see the eczema. Eczema, literal skin is going to appear boiling like appearance. So it is acute eczema where there are going to be vesicles oozing and crusting over the body. Next is chronic eczema. In this, because of the constant itching over the bodies. Remember, eczema patients are going to have very important symptom, itching, right? There's going to be lichenification, which is going to have these 3 changes, which are nothing but the black colored skin increase. Pigmentation will be there. Skin is going to appear very, very thick, and increased skin markings will be there. So these 3 changes put together, we are going to call it as lichenification of the skin. Lichenification of the skin. And remember, ACD and ICD are important types of contact dermatitis. Dermatitis is eczema, dermatitis, we can use broadly as the same, one and the same. Hair dye is going to consist of paraphenylene diamond, PPD, which can produce ACD. Nickel in the metals is going to act as the adulterant, which is going to produce the ACD. And in the bindi, there's going to be paratertiary butylphenol, which can again cause ACD, and the cement potassium dichromate can produce the ACD. What is the investigation of choice to diagnose the patients of the ACD, allergic contact dermatitis? It is a patch test. And what are the timings at which the readings are taken? There are going to be 2 readings. The first reading is taken at the 48 hours. Second reading is taken at 69, sorry, it is 96 hours. Okay, it's a 96 is the best reading. 48 hours, it is the first reading which we are going to take. Okay, right, chalo. Next is atopic dermatitis. Here, remember, the patients are going to have associated atopy, and there's going to be very interesting phases in these patients. 3 phases will be there: infantile phase, childhood phase, adult phase. Infantile phase, the lesions are going to be precisely present on the face and the extensor surfaces. Face and the extensor surfaces. And in the childhood and the adult, the lesions are going to be classically present over the flexural areas. In the childhood, even the face can be affected. And this atopic dermatitis, the diagnosis is not with any investigation of choices, just the clinical examination which is prepared by the Hanifin Rajka criteria, in which the patient should have must have pruritus, and they should have the typical morphology distribution. Just now we have discussed in the infantile childhood and adult phase, and it is a very chronic and chronically relapsing dermatitis, and personal family history of atopy is also very important in these patients. Ophthalmic manifestations: cone-like cornea, keratoconus, shield cataract, anterior subcapsular cataract can be there in these patients. Denny Morgan fold, additional fold infraorbitally can be seen, and also we can see Hartogisen due to the continuous rubbing. There will be loss of the eyebrows, which is called as a madarosis. So these are all the features related to the atopic dermatitis. Very important to remember from exam point of view. Next is urticaria, which is due to the mast cell disorder in which there is going to be histamine release, which is going to produce this dermographism, that is ability to write over the skin. Literally, dermographism is written here. Next condition is urticaria pigmentosa. Remember, this is not a type of urticaria. This is because of mast cell proliferation. So that's why it is also called as cutaneous mastocytosis. Because of the mast cell proliferation, the skin is going in the children. Remember, this is of the children. The hyperpigmented macules and patches will be seen over the body, mainly over the trunk. And if you happen to scratch or just tickle one of these lesions, then what is going to happen is rubbing of this lesion is going to release histamine, because of which there will be erythema with urticarial halo developing, and this is what is called as Derriere sign, which is positive in the patients of the urticaria pigmentosa. Very important previous year question which was asked. Okay. This is a child who is presenting with yellow greasy scales present on the scalp. What do you think is this? This is seborrheic dermatitis of the child, and this is what is called as cradle cap dermatitis. This is a cradle cap dermatitis, which was once asked as an image-based question. Cradle cap dermatitis. Okay. Parasitic infestations, ectoparasitic infestations, scabies, which is produced by Sarcoptes scabivar hominis. It is going to present as these pathognomonic burrows, especially in the web spaces and also other areas which are collectively called as circular febra, which are nothing but the web spaces, the wrist, the antecubital fossa, the nipples, the umbilicus, and the genitalia. So all these areas are going to have the papules, itchy papules. Itching is more common in the night time, right? And the burrows are going to be present, especially in the stratum corneum layer, but not deep. Okay, only till the stratum corneum layer. And if you look at this in the KOH mode, it is going to appear just like a, just a simple turtle, but it's going to have two pairs of anterior legs and two pairs of posterior legs. Treatment is going to be with topical agents. Topically, commonly which is used is permethrin. And apart from this, we are also going to use oral medication, which is the ivermectin. So topical permethrin, oral ivermectin. And usually patients of scabies are going to have 10 to 15 mites over the body. But in the case of Norwegian scabies or crusted scabies, remember these patients are going to have most severe form of the scabies, which can also produce the erythema of the body. This is called as erythroderma. And these patients are going to have million. These are literally we can call these are slum dog millionaires. So they are going to be very poor usually, which who are immunocompromised because of the HIV, or they can be having the sensory loss because of the leprosy. They are vagabonds. They will roam around here and there without any proper personal hygiene, because of which they are becoming millionaires, slumdog millionaires. And these are going to present with hyperkeratotic plaques, and there can be erythroderma, and these patients are going to die if we don't treat them on time. Treatment is going to be with ivermectin and also combination of permethrin. So pathognomonic lesions seen in the scabies are burrows. Patient presented with lesions in the interdigital clefts. Oral drug which is used is ivermectin. Remember these type of questions. You should be very careful. Patient interdigital cleft, that is web spaces. You may think scabies, and first option may be permethrin, but the examiner is asking you oral drug. So be very careful. Read the question very carefully. Ivermectin is the oral drug which is used in these patients. Incorrect about adult scabies. So adult scabies, remember burrows are pathognomonic, absolutely right. Itch mites, burrows and streptococcus, absolutely correct statement. Ivermectin, it blocks. This is the mechanism of action of ivermectin. So remember, dear students, scabies, adult scabies is not going to involve the face, palms, and the soles, but childhood scabies. In the child, if there is scabies, this was in fact the recent question. It can affect the face. It can affect the palms and soles, and in fact, palms and soles can have very classical vesicular lesions, which can be seen. This was a recent INA question, so be very careful. That may also be asked. So Norwegian skip is usually seen in patients on chemotherapy or those are having reduced sensation. So these are all the associations. And this is how the clinical weakness can be asked. 7-year-old intellectually disabled, mental retardation. So they are unable to take care of themselves, hygiene, presenting with vertic crust on the trunk. Severe fissuring and scaling is present. What to think as a diagnosis? You should always think about Norwegian scabies or also called as crusted scabies in these types of patients. Okay. Vagabond's disease is caused by Pediculosis corporis. Vagabond's disease caused by Pediculosis corporis. It is nothing but the body louse which is going to be present over the clothes. It is a lice, it is going to be present on the clothes and it is going to come onto the body whenever it wants to feed on the blood. Can you name any other conditions in SPM which are also transmitted by the body louse? Relapsing fever, trench fever. Okay, so all those are very important from PSM point of view for you to remember. Okay, identify this disease from the picture. You are able to see that there's elephantiasis which is present. This is an image based question which was asked previously. Cutaneous tuberculosis, yes. Cutaneous tuberculosis, lupus vulgaris. Lupus vulgaris is going to present as an annular lesion. Annular lesion, you can see here there's another annular lesion where there is a scar formation and the periphery is very active. This is the most common type of cutaneous tuberculosis in the adults. Lupus virus. Next is scrophulodderma, which is the commonest form of tuberculosis in the children, and mode of spread is going to be from the contagious spread, that is underlying lymph node, bone or joint are going to have this MTB bacillus. Most common focus of infection overall is the lymph node, that to specifically cervical group of lymph nodes, right? And this is also presenting over the neck. Subcutaneous nodules are there. What is the diagnosis? Yes, it is scrophulodderma, which is also called as tubercular lymphadenitis, is the another name which can be used by the examiner. Now related to some drug eruptions, so fixed drug eruption. So what are all the important drugs to remember? It could be NSAIDs, it could be metronidazole, after which the patients are going to develop this dusky red hue, surrounded erythema is there. And what is the characteristic point related to this special feature? Always the lesion is going to heal with a very bad pigmentation. Pigmentation is going to be left, and it can also affect the oral mucosa and also genital mucosa can also have this FD. And this was in fact the recent FMG question. Truck driver, herpes infection is present near the lips. What is the skin lesion which is present over the palms is the question. So these are the target lesions. Erythema multiforme, very good, absolutely correct. Next is SGS and TN. Drugs are implicated more than 90% of the times for Stevens-Johnson syndrome and toxic epidermal necrolysis. So less than 10% body surface area, it is SGS, more than 30% is TE and toxic epidermal necrolysis. Remember, in this patient, mucosal involvement is very classical, presenting as mucosal hemorrhagic crusting. And apart from that, the entire body can show sheet-like epidermal peeling because of the underlying, what is the problem here? It is necrosis. So because necrosis is the cause for sheet-like epidermal peeling, this is not called as Nichols-Kiss sign, but this is what is called as pseudo-Nichols-Kiss sign. Pseudo-Nichols-Kiss sign. Okay. And bleomycin is going to produce this flagellate dermatitis, very important image-based question, and also minocycline-induced blue pigmentation you can see over the acne scars. So this is how the examiner can ask you anticonvulsant drug, and this is a picture which is shown. What is the diagnosis? It is fixed drug eruption, which you have to think of. And this is how the classical history will be there. Same rash at the same site once the same drug is taken. So this is fixed eruption, the fixed site because of the fixed drug. All can be caused for erythema multiforme except infectious mononucleosis, mycoplasma, collagen vascular disease. All of them can be caused for EMF, but not chronic renal failure. Chronic renal failure is not the cause. Some genodermatosis and phacomatosis, neurofibromatosis, the patients are going to present with neurofibromas. So these are the neurofibromas which are present on the body. So this is NF1 which we are talking about. And the patients are going to have this dark colored hyperpigmented patches. These are called as cafe ole macules, and these are the small freckles which are present over the axilla. So this is what is called as Crovey sign. This is what is called as Crovey sign, and this is the plexiform neurofibroma which is present congenitally because of the involvement of the entire trunk of the peripheral nerve sheath. And these are the Lish nodules which the patient can have over the iris, which are the iris hematomas, Lish nodules. And tuberous sclerosis complex is also called as the epiloia, which stands for epilepsy. Patients can have low IQ and they are going to have this very classical adenoma sevation. So epilepsy, low IQ and adenoma sevation put together, we call it as epiloia. The other skin findings which can be seen in these patients are ash leaf macules, which are depigmented lesions. Chagrin patch can be present, which is nothing but a collagenoma. And adenoma sebaceum, it is also called as very classically angiofibroma because it is a proliferation of the blood vessels and also the fibrous tissue. Coherent tumors, periangular fibromas can be present in these patients. And important point to remember is though the term fibroma is present, these lesions are seen in tuberous sclerosis but not in neurofibroma. So that is important for you to remember, not neurofibroma. In examination, sometimes you may get confused, but that's why I have written that point for you to diagnose easily understand. Patient presenting with axillary freckling, what do you think is the diagnosis? Neurofibromatosis is the first thing which you have to think of. Most common neurological tumor with NF2, this is ectopic acoustic neuroma, schwannoma. Okay, and low intelligence is there, epilepsy history is there, and you are seeing some small papular lesions over the face centrofacial area. So this is epiloia, adenoma sebaceum, tuberous sclerosis. So this is carpet taxon, connective tissue disorders, which is seen in the case of discoid lupus erythematosus, right? And this is the patient present with fever, oral ulcers. What do you think is the diagnosis? This is a butterfly rash. Butterfly. So this is SLE, systemic lupus erythematosus. Salt and pepper skin can be seen in the patients of scleroderma. So where hyperpigmentation and depigmentation will be present juxtaimposed. Now this is how you can differentiate between the rosacea and the SLE. So in rosacea, there's going to be this red colored cheeks and also telangiectasias will be there over the nose. Okay, next is acanthosis nigricans. So this is going to present as velvety texture present over the axilla, neck, and also over the groin. It can be there, and it is most importantly associated with the obesity more than diabetes mellitus. So I hope सबका नींद उड़ गया. चलो. Next, pellagra and acrodermatitis enteropathica. So these are better read together. So pellagra, because of niacin, vitamin B3 deficiency, usually seen in the patients who are having the jowar, maize, and also alcohol intake most commonly. And this is going to present with 3 Ds. So photodermatitis, diarrhea, and dementia. Okay, treatment is going to be with vitamin B3 supplementation. And this necklace, what is this necklace called as? Castle's necklace. Very good. Acrodermatitis enteropathica is due to zinc deficiency, and the diet is going to be most importantly after weaning. The presentation is of the child is going to be classically seen, and it's going to present as acrofacial. So it is periorifacial, acral dermatitis, diarrhea, and alopecia. So Dan, treatment is a lifelong zinc supplementation. Once you give the zinc, this the treatment is going to be very, very great. Okay, right. Pityriasis alba and Pityriasis, indeterminate leprosy. These are, other things which you have to remember. Pityriasis alba is going to be seen in the children or the face has hyperpigmented patches, but these are going to be multiple in number. Or indeterminate leprosy is going to be presenting with single lesion over the face. Okay. Scaling is very classical for Pityriasis alba because Pityriasis wherever is there, scaling will always be there. Sensations may be normal or impaired in the indeterminate leprosy, whereas skin atrophy is going to be present in the indeterminate leprosy. Okay, so next is leprosy, Hansen's disease. So you need to know few important points related to leprosy. TT leprosy is going to present as an annular lesion. Center of the lesion is going to be clear, and you can see this is appearing like a saucer. So this is also called described as saucer right way up lesions. Whereas in the BT leprosy, few points to remember, these BT patients are the most common type of BT Hansen's disease in India, and they are going to have the small surrounding lesions. These are what are called as satellite lesions. So you can remember Bharat has sent so many satellites recently. So that will help you to remember that BT leprosy is having these satellite lesions. Okay. Mid borderline leprosy, important points to remember. It's a polymorphic skin lesions will be there, and it's going to present with both well-defined, ill-defined lesions. So it is dimorphic, and it is very good. Moyes, you remembered it is BB's wife. So wife and husband, if you remember, you can remember all the important points related to this. So wife, if she is angry, she will keep the saucer in an inverted fashion, because of which there's going to be a tea which is going to pour on the face, and that will help you to remember the wife and husband always will quarrel, just like Tom and Jerry, the mouse and the cat. So that will help you to remember the Swiss cheese appearance or punched out appearance. And also not only that, wife and husband are going to go on world tour, how much ever they are going to quarrel, but I'm here, but Tom and Jerry is there in one single person. I want to meet you in Cerebellum. Come to the Cerebellum. Come to the Cerebellum. Okay. So they are going to have a happy tour all over the world. So that will help you to remember geographic map-like appearance can also be seen in these lesions of the BB leprosy, which is also called as mid-borderline leprosy. So all these points are covered. Next is the borderline lepromatous leprosy, in which case we are going to see the skin and the nerve involvement, which is almost symmetrical. Almost symmetrical. Next is the lepromatous leprosy, in which we are going to see the lion-like face. The patients are going to have madarosis. There will be Glavin-Stocking peripheral neuropathy, Glavin-Stocking okay, glove and stocking anesthesia can be there. And in the reactions, remember, very simple to remember. Type 1 leper reaction is type 4 hypersensitivity, type 2 is type 3. So 1 plus 4 is equal to 5, 2 plus 3 is equal to 5. So that will help you to remember that in this type 3 hypersensitivity reaction, there can be new lesions because the immune complexes can deposit anywhere over the body. So there will be erythematous tender evanescent nodule. So that's why it is called as erythema nodosum leprosum, right? And it is seen in the case of lepromatous pole, that is we can say BL and LL. Here we can see the borderline pole, that is BT, BB and BL. And here pre-existing lesions are going to become inflamed because the cell-mediated immunity is going to act against the M. leper bacilli which are present in the skin lesions and also in the nerve. So nerve is going to be very bhayankar affected. Neuritis, and the treatment for both these conditions is continue MDT. You should not stop the MDT, continue it, and we should add the steroids, that is prednisolone. Thalidomide is gold standard for type 2 leper reaction, but we are not going to use because it is very expensive and also it is teratogenic. Treatment, this might have been covered in the PSM, but still just I want to tell the points. PB and MB, depending upon what is the patient having, we are going to use the three medications are going to be the same which are going to be used in these two patients, and the duration is going to be the different 6 months in the case of the PB and 12 months in the case of MB. Very easy trick to remember the dosages. Rifampicin is once monthly 600 mg. Dapsone is 100 mg daily. Clofazimine is going to be given both as once monthly and also daily. Once monthly dose is half of that rifampicin dose, which is half of 600 mg is 300 mg. Daily dose of clofazimine is half of the daily dose of dapsone. Half of 100 mg is 50 mg. So very easy way to remember, and the same medications are used in the multibacillary also. How to diagnose multibacillary? If the patient is having more than or equal to 6 lesions, and even if one nerve is thickened, and if the AFB is positive, then we are going to consider the patient as multibacillary. And these are the questions can be asked. Hypopigmented rash, satellite lesions are present. What is the diagnosis? BT leprosy. Swiss cheese appearance, Swiss cheese, BB leprosy, borderline leprosy, mid borderline leprosy. All of the following diagnosis. Remember, lepromin test is only useful for the prognosis, but not the diagnosis. Okay. And thalidomide is effective in the case of type 2 lepra reaction. Right. Some malignancies, superficial spreading malignant melanoma is the most common spreading, most common type of malignant melanoma. Nodular variety is the most aggressive form because remember malignant melanoma, The prognosis is depending upon how deep the melanocytes have reached. So that's why nodular variety is going to definitely deep. So that's why it is most aggressive. From acral lentiginous are most common in the Indian subpopulation, or we can say dark skinned individuals. This was a recent question which was asked. So yeah, what is this? What did I write? Indian, yeah, Indian skin, or we can say dark skin individuals. Dark skin individuals. Okay. So this ABCD criteria is what is used. So we have to look the lesion is asymmetrical, and if the borders are irregular, and if the color is irregular and diameter is more than 6 millimeters, and is evaluation any sudden appearance of ulcer formation. So all these criteria are going to tell that yes, this is not normal pigmented lesion, it is a malignant melanoma. And who is this actor? Hugh Jackman. He has basal cell carcinoma. He is still alive. So that will tell you that BCC is not going to show metastasis. It is locally invasive tumor, but it will not show metastasis. Okay. And it is going to present as pearly white nodule with surface showing telangiectasias. So this telangiectasia you can clearly see, and the line joining above the angle of the mouth and the earlobe. That is the above this, the BCC chances are very, very high. And the most common presentation is in the form of nodular ulcerative lesion. And this is a xeroderma pigmentosum, which is because of the nucleotide excision repair defect, where the damaged DNA are going to accumulate, and unfortunately these patients are going to have the genomic instability, which can lead to carcinogenesis in the form of BCC, SCC. They can also have AML, ALL, you name it, and they can have it. Even malignant melanoma also can develop in these patients. Okay. So that is end of the marathon session. But I also just want to summarize, or we can say just quickly see some important questions which were recently asked, which you might have missed them. So these are the questions which were asked in the recent examination. So what is this patient of vesicular lesion for upper lip are there, and this is a target lesion which you are able to see. What is the diagnosis? Yes, it is erythema multiforme. We have already discussed this. Okay. And this is the next level which we have already told. Tamil Nadu is endemic for mycetoma. So you all know that swelling is there, tumefaction, sinuses are there, and there are granules. GST is there, so it is mycetoma. Black granules are there, so it is eumycetoma. But the exam is asking you management strategy, not the diagnosis. So here, what you have to do, we have to give the antifungals, and we have to do surgical debridement. So that's going to be the treatment which we are going to. It's not, some students thought that this limb is appearing bad, so we'll cut it. So they have marked they have marked amputation as answer. No, we have to give the antifungals, and we have to try conservative treatment. Every time FASAC is not the thing. So next is 27-year-old individual develops a transient genital lesion that resolves spontaneously. After 2 weeks, the development of painful lymph of the bubo is there, fever, which chlamydia trachomatis seroid. So what is the diagnosis for this case? Can you tell me what is the diagnosis? Yes. Yes, very good. It is L1, L2, L3. Diagnosis is very good. It is LGV, which is going to present as a primary genital lesion, which is going to be very, very transient. It may be go on unnoticed by the patients. And bubo is seen in the case of LGV and also chancroid. Okay. So that's why this particular history has been mentioned in the question. Okay. And this is, so many times it has been repeated. Whenever you see a patient who is having leprosy on MDT, or was stopped on the MDT, but still they can, after the completion of the treatment, also they can develop the lepra reaction. That is important point to remember. One thing. And the previously existing lesions are now developing the inflammation. So it is a type 1 lepra reaction. Whatever may be the reaction, continue the MDT and start the oral steroids. That is going to be the treatment which you are going to use. And this is a young child, a scale itchy rash, which is present on the face and extensor surfaces. Itching is intense at the night time. Caregiver reports positive family history of asthma in the father. Okay, child has a dry itchy eczematous. This was the exact question. So students, they felt, because nighttime itching is there, they have marked the scabies as the answer. But be very careful, dear students. The family history of asthma in the father, asthma, bronchial asthma, it could be because of atopic dermatitis. It could be one of the criteria in the Hanif and Rajka, which was mentioned here. Dry, itchy skin, eczematous, That is one more major criteria in the case of Hanifin Rajka. So you should always think of the possibility of atopic dermatitis in this patient, and I'm happy that all the students have marked the atopic dermatitis in this case. And this is another case, the diabetic individual presenting with asymptomatic skin lesion since 1 year, and non-scaly annular lesion is present as in the image over the dorsum of the hand. So remember, very important two possibilities you will think of here are tinea corporis, and the other one is granuloma annulare. And here, because it is asymptomatic, there is no itching, and also it is non-scaly, we are going to mark it as granuloma annulare. Remember, if the examiner mentions that it is itchy and scaly, then you will mark the tinea corporis as the answer. Okay, right. Next is the truck driver is there here. Okay, he's having single painless ulcer in the oral cavity, painless ulcer in the penis is there, and there is non-tender, or we can say painless lymphadenopathy. So what is the diagnosis for this case? It is syphilis. So the examiner may also, they can give you that this single painless oral ulcer in the oral cavity may be because of the oro genital sexual practices. Okay. Next is this thing. Okay, again, STD questions were asked, so many of them. Painful genital ulcer, characterized with ragged edges, tender lymphadenopathy is there. So painful genital ulcer, painful inguinal lymphadenopathy. What could be the two possibilities? One is herpes, other one is chancroid. Herpes is not at all there in the option, so it's going to be the chancroid, Haemophilus ducrei. So these are recent INA questions. So we have already discussed this. Pseudo-Nikolsky, what is the SJS and TN are the conditions where pseudo-Nikolsky can be seen. Positive Nikolsky can be seen in the case of the Pemphigus vulgaris. False Nikolsky or Nikolsky negative is what is observed in the case of bullous pemphigoid. Remember, this Pemphigus vegetans is a variant of the Pemphigus vulgaris, in which we are going to see this a tongue which is appearing as like a cerebra. So cerebriform tongue. So this is DCAB, which is option number B. Okay, very good. Right. So this is a cerebriform tongue, can be seen in the patients of Pemphigus vegetans. Next, this is very simple for you. It is not even. This is one thing which I told you. Child present with itchy vesicular lesions of the palms and soles. So you should think of it is infantile scabies. Infantile scabies. Okay. And this is also very important. Child having scalp scaly lesions with itching and hair loss. So many students marked it wrong. Remember, this is a patient. This is a child presenting with itchy hair loss, scaly hair loss over the scalp. What is the diagnosis you will think of? Diagnosis is tinea capitis is the diagnosis which you will think of. Remember, dear students, psoriasis, even if it affects the scalp, it will not cause hair loss. In psoriasis, there is no hair loss. So it is a tinea capitis in child, which you have to think of. So the answer is going to be the oral antifungals. Oral antifungals. It's not chirion. Chirion will present as a boggy swelling. There is no boggy swelling here. There is just hair loss which is seen. Okay. So it is tinea capitis, oral antifungals. What is oral antifungal which you are going to prescribe in these patients? What is that oral antifungal? So is it terbinafine or itraconazole which is commonly used? No, it is griseofulvin. So this is the overall drug of choice. Very good. It's a, yeah, some students have marked it correct. Griseofulvin. Remember, griseofulvin is the overall drug of choice. But if the examiner specifically mentions that it is a trichophyton species producing tinea capitis, then you can mark terbinafine. So T for terbinafine, T for trichophyton. T for terbinafine, T for trichophyton. Okay, right. And this is another question. A neonate is brought with the lesions as seen in the image. Baby is feeding normally, no fever, no hypertension, no sense of any shock. What is the most probable diagnosis? What do you think is the answer for this question? Okay. So I can see many students are answering staphylococcal scarlet skin syndrome. Be very careful to read the question, dear students. So it is a neonate. So it is not a child, it is a neonate immediately after the birth. If you happen to see these type of lesions over the body where the erosions are there, some vesicles are there, bullous lesions are there, and especially in a child who is feeding normally, There is no problem in the feeding, no fever, no any other problems. So this is a classical picture of epidermolysis bullosa, which is nothing but a mechanobullous disorder. It's a mechanobullous disorder. This was not asked till now in FMG, but maybe it may be asked. Okay, so it is a mechanobullous disorder, epidermolysis bullosa, which is nothing but a genetic condition. So in this, just remember in the skin, there is going to be defect genetically from the birth in some proteins, because of which the skin is going to be weak, leading to the development of vesicles and bullous lesions over the body. So why is it not Staphylococcus scarlet skin syndrome? Very simple. So usually it will not be a neonate, it will be a child. And not only that, the child is going to have fever, they are going to have a tenderness of the body, and they are going to not feed normally. Their feeding is also going to be abnormal, because while the time the mother is holding the child, there's going to be a lot of pain because of the underlying acantholysis. So there will be tenderness and there will be pain. So all these points are against the Staphylococcus scarlet skin syndrome. So we can roll this point out. Okay. Right. And what else? This is the recent INA question. So patient painless black lesion over the heel. Okay, what is the best investigation to confirm the diagnosis? What do you think is the diagnosis? First of all, tell me that. What is the black lesion? Whenever you see the black lesion? Melanoma is a diagnosis which you have to think of, and skin biopsy is the best way to diagnose the patients of melanoma. Where is the tattoo ink present in the skin? If you do a tattoo, like I have done a tattoo for myself. So where is the tattoo ink present? So it is going to be present at the dermis. It's going to be present at the dermis level. Okay. So this is a very, very, very easy question. So even in INA, this question is asked. So most likely it may be also asked in the case of FMG exam also. So these are the clinical features which are there. What do you think is the diagnosis? NF1. Very, very easy question. So they have given cephalomacules, Lisch nodules, and they have this. So optic glioma can be one malignancy associated with NF1, because of which proptosis can happen. So this is a proptosis which is happening because of the optic glioma. Okay, so these are all features are all of them are features of NF1. So Jeevita, avani modalupettadu అందరూ శ్రద్ధ తీర్చేస్తుంది. I hope all of you have enjoyed this session. And if you have any doubts, you can ask me. You can WhatsApp me or hi sir to join the groups. And I hope you have enjoyed this session.